Hi everyone, welcome back to UWorld's NCLEX review. It is so great to see you all here today. My name is Samantha. I am a nurse here at UWorld, and today our topic at hand is going to be the antepartum period of pregnancy, meaning that problems we encounter while pregnant before the labor process begins. So we're going to start out with hyperemesis gravidarum, and then we'll move on to our hypertensive disorders of pregnancy. Now that hypertensive disorder content works like a spectrum. We're going to start with the disorder of least acuity, which will be gestational hypertension, and we'll progress down that acuity spectrum to preeclampsia, eclampsia, and lastly we'll cap it off with HELLP syndrome. So this topic hits home because I am an antepartum nurse, so I'm excited to get into today's content. I feel like when it comes to maternity content, the labor and delivery period, as well as a little bit of postpartum, kind of get the most attention. However, that labor process is really only a few days long, whereas the antepartum period is 9 months long. So it's definitely worth our time to study this today. We also get a lot of requests for maternity and antepartum topics, so I really hope that we drive those home today for you all. A couple of housekeeping things before we get started. We do take into account y'all's recommendations and suggestions, so definitely let us know what you want to see us present more on. There will be questions peppered throughout today's videos, as well as NCLEX style questions at the end, so make sure you stay tuned for those. This live will be on demand, so if you have to duck out early or kind of come in and out, you're always able to revisit it in the future and check out any of our social media channels. Personally, I think that YouTube channel is the easiest one to search because there's actually a search functionality. As always, drop your comments and questions into the chat. We have Nurse Jasmine standing by moderating today. We always want to hear from you guys, so let us know any questions that you all have or any comments, or of course answers to today's questions as we move on. So let's get that chat started by dropping in, letting us know where everyone is joining from. Who is a US viewer? Who is an international viewer? We're always curious to see who is joining and how far UWorld reaches. So definitely let us know. I'm going to get into that chat and see what everyone is saying. Give me 1 second. Alrighty, great job. So let's start out with hyperemesis before we move on to the hypertension-based content today. So with hyperemesis gravidarum, this is the severe and persistent nausea and vomiting. It goes above and beyond what can normally be expected, because most maternal clients are going to experience some nausea, some bouts of emesis within that first trimester, but typically it resolves in a normal client by a second trimester. Unfortunately, the exact cause of hyperemesis, which goes beyond those normal limits, is unknown. Experts do believe that increases in pregnancy-related hormones are to blame for this disorder, which is supported by the fact that women who are having multiples, like twins and triplets, are more likely to experience this disorder, and that's because they experience greater pregnancy-related hormone increases than a maternal client that's carrying a single gestation pregnancy. So many clients suffering from hyperemesis will need to be admitted to the hospital at least once throughout their pregnancy, and this is due to the unfortunate symptoms that this disorder causes, which leads us to our clinical features. So our clinical features for hyperemesis include weight loss at or greater than 5% of the pre-pregnancy weight. So typically we associate being pregnant with gaining some weight, but these hyperemesis clients unfortunately are so sick they actually lose weight initially. Clients will be dehydrated, they'll have poor skin turgor as evidence of this, hypotension, compensatory tachycardia. We can see increased urine-specific gravity, which essentially means concentrated urine because they're dehydrated, or increased hematocrit, which means concentrated blood, again, because they are dehydrated. Clients can experience electrolyte imbalances. Two big ones here can be hypokalemia, and this can even lead us to metabolic alkalosis. And they'll experience ketonuria, which is the liver essentially creates energy by breaking down existing components. When clients are unable to consume things because they're so sick and so nauseous, we're not getting nutrients from external sources, we're having to break it down from internal sources. So the liver creates energy by breaking down existing components, and ketones in the blood are going to be a byproduct of that process. We know that the kidneys filter our blood, which is how to make urine, and that's how ketones can end up in our urine. Now, our nursing interventions, the bread and butter of hyperemesis is going to be in the nursing interventions. We're really working here to increase client comfort. We're going to try to alleviate that vomiting, relieve the nausea, replace some of those fluids lost, and correct any underlying fluid, electrolyte, vitamin, and nutritional imbalances. So how do we do this? We're going to treat with IV fluids. I know when I was on the antepartum floor, we would come in, these clients, and we would give them like a banana bag, a bolus before we even started, just a drip hourly. So they're really getting a lot of fluid replacement just right off the bat. We're of course going to give antiemetics like a Zofran, a Phenergan, a Reglan, and then we're going to give thiamine like a vitamin B12 just to correct any of those underlying vitamin imbalances. Now, daily weights will be really important here. We always want to take those at the same time of day because we can know that can fluctuate throughout the day as we eat, as we drink. We're going to initiate calorie counts after these clients get off of NPO requirements. Now, initially when they're admitted because they're so sick, we're going to start them NPO just for some digestive rest, give that GI system a little break, and we'll slowly advance the diet from clear to full liquids and then eventually incorporate solids back into it. Obviously, when we get to that solid place, we're going to be incorporating those calorie counts. Clients may need to be on cardiac monitoring because this can cause potassium imbalance. And we know that potassium imbalances in the body can lead to cardiac complications. Eyes and nose are super important, and eyes are not just going to be our typical eating, drinking, and excreting, but we're also going to have emesis that counts towards our output. So always important to make sure we're including that in our O's. We're going to check the urine for ketones, and all of these interventions were really tailored to that maternal client. But remember, in an antepartum client, you're really looking at two clients in one. We need to check in on that fetus as well. So we're going to do this through fetal monitoring. We're going to check the fetal heart rate when these clients are earlier on in their pregnancy and those early, really first trimester. Once they're about at 20 weeks and beyond, we're going to start doing NSTs, which stands for a non-stress test. This measures how well the fetus is adapting, the variability, the accelerations that we see, and we use this for a little bit later on in the gestational period just to make sure that we check in on the fetal client as well. So the goal for any client is that we get them better and they can eventually get discharged to manage this process on their own at home. So we need to do a lot of teaching in order to get them there. Now, teaching for hyperemesis is mostly going to be diet-based. We want to make sure these clients know that small and frequent meals are what we recommend. We want them eating about every 2 to 3 hours. We really want to avoid that empty stomach because this can be a trigger for nausea. We want them to snack as soon as they get out of bed, never go too long without eating because that can bring on more nausea. Clients should be avoiding strong odors in foods or really heavy greasy meals. So things like spicy foods, pungent odors, and fried greasy heavy foods should be avoided. Clients will need to sit up after meals, which will also help with some acid reflux. They need to be drinking plenty of fluid at home, and the smaller the sips, the better, just to give them a little bit throughout the way. Too much fluid at once can also be a trigger for nausea and vomiting. Cold carbonated beverages can be really therapeutic for these clients. Things like ginger ale can be really soothing to the stomach, and we want these clients to know how to choose the right foods. At the beginning, those really dry, high-carb foods like bread, crackers are going to be going down a little bit easier than other ones, and they're most likely to stay down. We also prefer cold foods rather than hot foods too when it comes to these clients that are so sick and nauseous. A tip that I got from an old hyperemesis client that I had was whatever food you wanted or you were craving before you got sick, you have the best chance of keeping down. So when you are able to eat what you were craving prior, and it helps just a little bit with the mental part of being able to keep this food down. So that sums up our hyperemesis part of today's lecture. Now let's take the jump into the hypertensive disorder hypertensive spectrum of disorders during pregnancy, So we have a great table that shows this spectrum and how it can progress. We're going to pull that up for you. Remember that anything we put up here, you're free to screenshot, take it with you, keep it for your own reference. It's a great way to follow along today's hypertensive content. If you ever get lost, just jump back to this table to refer to where we are. But let's start out with gestational hypertension or hypertension of pregnancy. So gestational hypertension, of course, will be separate from chronic hypertension because chronic hypertension was present before pregnancy happened. A patient with chronic hypertension will continue to have hypertension throughout pregnancy. Unfortunately, pregnancy is not a magic cure for that, but it differs from gestational hypertension because gestational hypertension is new onset hypertension at 20 or more weeks of gestation, and there has to be no sign of end organ damage, no protein in the urine, and it will typically resolve after the delivery of the placenta after birth. Now, there's still a lot of research to be done on the genesis of gestational hypertension. We don't know the exact cause as of yet, but doctors do believe it has to do with the placenta as well as the body's circulating hormones. Now, clinical features of gestational hypertension, they're going to be blood pressure that's greater than or equal to 140/90. Now, important here, we have to get this measurement in 2 separate blood pressure measurements that need to be taken 4 to 6 hours apart. We want to make sure it's not a fluke thing. The client wasn't just worried because they were in their provider's office. Maybe they just went through traffic to get there. We want to make sure it's not a fluke, so we take them 4 to 6 hours apart. Typically, there will be no lab abnormalities in gestational hypertension, no proteinuria. And the really scary thing about this is many pregnant clients actually feel fine. They're totally asymptomatic. They don't even realize that their blood pressure is elevated unless they are frequently monitoring it. So what are the complications here? The real danger of gestational hypertension is its potential for disease progression to move down that spectrum to preeclampsia, eclampsia, and it can even put us into HELLP syndrome at the worst. We're going to cover these later in the lecture today, but this is the spectrum of acuity that I was referring to earlier. So other complications of gestational hypertension include restricted fetal growth. You may see this denoted as IUGR, which stands for intrauterine growth restriction. So if you ever see that on a chart, now you know what it means. Gestational hypertension can cause placental insufficiency. So we're not adequately supplying the baby with oxygen. We can even see placental abruption, meaning that placenta starts to peel off the uterine wall and it's unable to supply the baby with oxygen. Now it can be partial, where only a little bit peels off, or of course it can be a full abruption, which is a medical obstetrical emergency. A key sign of this will be a rigid abdomen, and hint, hint, wink, wink, you may see that in a question at the end of today's lecture. Other complications that can occur from gestational hypertension include maternal stroke, pulmonary edema, and in the worst, most severe cases, maternal or fetal death can occur. So what are our nursing interventions? When these clients come into the office, for instance, most of this monitoring will be done outpatient unless it progresses. We're monitoring that blood pressure, of course, and we're also monitoring weights. These hypertensive disorders of pregnancy have a proclivity to cause these clients to gain weight really, really quickly, which we know also weight gain is a symptom of a normal, healthy pregnancy. So we have to really make sure we're keeping a close eye on weight. And if we're seeing really quick, sudden increases in weight, that's going to be a sign of quick swelling and edema. Other things we're going to look for as far as that quick swelling and edema include swelling of the hands, feet, and face are the first places this will typically present. So if one day you're feeling totally fine and the next day your ankles are absolutely as thick as they've ever been, this is a cause to call your doctor or go and seek treatment. Once a maternal client is identified as having high blood pressure, she will need to monitor it at home consistently with a dependable blood pressure monitoring system. She will need to report symptoms like headache, increased swelling, quick weight gain, or blurry vision to her provider, and definitely need to monitor those kick counts and report any decreased fetal movement. A client with gestational hypertension should anticipate a slightly early induction of labor as well. Now, when the client is eventually admitted to the hospital for that induction of labor, they need to measure their I's and O's, or the nurse will be measuring their I's and O's, excuse me. They'll test for proteinuria along with those other essential admit labs, and definitely monitoring for disease progression because, as we said, the big danger of gestational hypertension is that it can progress further down into preeclampsia, eclampsia, and so on. So speaking of those further complications, let's talk about preeclampsia. All right, so things are getting a little bit more serious here. Preeclampsia will be diagnosed as high blood pressure after 20 weeks of gestation, and it's going to be with proteinuria or with signs of that end organ damage. This is what really sets it apart from Gestational hypertension. Now, experts believe that preeclampsia is caused by the systemic vasospasm of the vessels that's caused by the placenta. The only real cure here is going to be delivery of the fetus as well as that placenta, but important to note is that preeclampsia can persist into the postpartum period. Postpartum preeclampsia is a relatively common thing that does happen. So our risk factors here, any client with existing chronic hypertension is going to be at a higher risk to developing preeclampsia, as well as any client with a past history of preeclampsia in a prior pregnancy. Diabetes mellitus also predisposes us to this, as well as multiple gestations. So a client carrying twins or triplets is more likely to develop preeclampsia. All right, so we're going to pull up our preeclampsia image, which is a great visual to accompany our lecture about what this is going to look like in a clinical setting. So there are two types of preeclampsia: preeclampsia without severe features and preeclampsia with severe features. Now, no shocker here, without severe features is going to be the less serious. This is blood pressure of 140/90 or greater with the presence of proteinuria. Now, the way we test for this in preeclampsia for this proteinuria is something called a 24-hour urine test. Now, if you've worked in an L&D unit or definitely an antepartum unit, this is so much of what we do. You do a 24-hour urine test by you start the test at the first void, which you actually discard. You do not add it to the test. That marks when you start, and everything else after that is collected in a hat in the toilet and then added to a jug that we keep over ice. For the rest of those 24 hours, we are collecting all of the urine. If we miss any of the urine, we actually have to restart the test. And then after those 24 hours are up, we take those urine jugs, sometimes it's one, sometimes it's two. One time I had 3, and you get a really good arm workout carrying it down to the lab to get it tested. Now with preeclampsia with severe features, we're going to have blood pressure of greater than 160/100. So really we're getting some high blood pressures here. This is at the point where it can damage organs. It's also really dangerous for that placenta because the placenta really can't withstand these high blood pressures. We can see thrombocytopenia, increased creatinine. We're going to be closely monitoring those LFTs or liver function tests like the ALT and the AST, which is going to be showing us signs of liver damage. Again, this can damage our organs. Clients will also commonly experience visual or cerebral symptoms. So things like headache, blurry visions, floaters in the vision, and this can be a warning sign of impending stroke due to these high blood pressures. Now, what are our complications here? Let's start on the maternal side. What can happen because of preeclampsia? We can see AKI or acute kidney injury. This can lead to pulmonary edema, ischemic stroke, even liver failure or rupture. Again, another important reason why we monitor those LFTs so closely. Clients can go into DIC, which is disseminated intravascular coagulation, which means problems clotting essentially. And preeclampsia is the precursor to eclamptic activity. So we can go into eclampsia, which is seizure activity. Excuse me. Now on the fetal side, what are the fetal complications that can occur from preeclampsia? These are mostly caused by not enough blood flow through that placenta. Again, that placenta cannot withstand super high blood pressures. This can affect the blood flow to the fetus. We can see placental abruption from this. That can be partial or it can be complete. We can see restricted fetal growth, that IUGR. We can see preterm birth a lot of times in preeclampsia, and unfortunately this can also lead to fetal demise. So what are our nursing interventions for our preeclamptic client? The only real cure for preeclampsia is going to be delivery of that fetus and the placenta. Our nursing interventions really revolve around preparing the maternal clients for birth. We're going to have hourly eyes and nose to make sure those kidneys are perfusing well. We want to make sure that we are checking reflexes, and we're checking both ends of the spectrum here. So really brisk reflexes can be an indicator of an impending seizure. We need to give antihypertensives to help bring down the blood pressure to prevent stroke. We're going to give a labetalol, which is a beta blocker that's safe to give during pregnancy. We can also give a hydralazine or an apresoline is what that's also called, and these are safe for pregnancy. We're going to want to make sure we do seizure prophylaxis. So the mom needs to be started on magnesium sulfate. This requires very close assessment because clients can become mag toxic. And we're going to also monitor our reflexes for this. So we talked about those brisk refluxes being an indicator of a potential seizure that could be on the way. Slow and depressed refluxes on the other end of that spectrum can show signs that this client is becoming MAG toxic. So we're definitely checking those refluxes, but we're checking them for both ends of the spectrum because either can mean a negative outcome. Other side effects of this magnesium sulfate drip is going to be things like feeling flushed, feeling hot, feeling sweaty. MAG is not the most pleasant drug to be on, so a lot of these moms are pretty uncomfortable. We're going to monitor I's and O's while this maternal client is on magnesium. These clients are going to be confined to the bed, so they will most likely have a Foley catheter or use a bedpan if they prefer. We're going to need to monitor headache, blurry vision, any of those visual or cerebral symptoms. Of course, we're closely monitoring that blood pressure, and in most cases, the maternal client stays on this MAG sulfate drip until 24 hours post-delivery. And of course, we're keeping up with those seizure precautions. So if the client were to seize, we're going to lay that head of the bed back. We're going to call in some buddies. We're going to document the characteristics and the length of the seizure. Nothing goes into the mouth during a seizure, no suction, no tongue depressor, and we're also making sure any restrictive clothing or sharp things are removed from the bedside or the bed. So if the client were to seize, they cannot injure themselves. Now, lastly, depending on the gestational age of the fetus, we're also going to give betamethasone. Now, this is a steroid, and it helps those fetal lungs to develop. Now, the fetal lungs are typically the very last things to develop. This kind of gives them a little bit of a boost. Typically, we give this via 2 doses. It is an IM shot to the maternal clients. Ideally, we're going to give these 2 doses 24 hours apart. Unfortunately, sometimes preeclampsia does progress so quickly that we don't have a full 24 hours in between giving this first one. We don't have 24 hours before this baby is born. So in this case, we're going to have to give them via provider order, which sometimes is 12 hours, sometimes it's 6. It's really as much as time will allow. So now let's jump back in to that hypertensive disorders of pregnancy spectrum. Where are we? We've been talking, where even are we in this spectrum? So we've covered gestational hypertension, we covered preeclampsia. Quick note on superimposed preeclampsia. This is just the fancy term for a client that had existing chronic hypertension prior to pregnancy, plus one of the following. So they had hypertension, they got pregnant, and then one more of the following popped up. They had new onset proteinuria, they had a sudden worsening and intensification of their existing hypertension, or they started to show signs of end organ damage. Maybe we're having kidney issues, maybe those LFTs are jumping up. We definitely have to make sure we are assessing that. Now, either form of preeclampsia can eventually develop into eclampsia, which is the presence of tonic-clonic seizures. This would be new onset, high blood pressure, really predisposes the maternal client and puts them at a risk for this. We give MAG sulfate as that seizure prophylaxis to help relax the system. In some cases, this is unable to stop those seizures, especially maternal clients that had limited prenatal care are at a higher risk to developing into eclampsia. So at the very end of the spectrum, our highest acuity syndrome is something called HELLP syndrome, HELLP. Before we move on to cover HELP, I'm going to ask a question to the chat. What does HELP stand for? Again, it's HELLP, so there's 2 L's, but this is an acronym and it does stand for something pertinent to our discussion today. So drop in the chat, let me know what HELLP syndrome stands for. I'll give you a few seconds. Drop those answers in the chat. Alrighty, I'll give you a few more seconds. I know you guys got this one. All right, and I see some great answers. Way to go. So HELLP syndrome is at the worst end of the spectrum. At this point, mom may need to be in ICU post-delivery, but this stands for hemolysis, elevated liver enzymes, and low platelets. So it is an acronym. At this point, essentially, some of our organs are starting to fail. We're having liver damage. We're seeing manifestations in the hematological system. Key signs and symptoms are going to be epigastric as well as right upper quadrant pain. Clients will be nauseous and vomiting and just in general feel really bad. Treatment here is going to be that MAG sulfate, very close monitoring of the blood pressure, meds to control it, prompt delivery, and in some cases even ICU level care post-delivery. So very serious. Definitely want to make sure we quickly touched on that one. So this leads us to our questions. We have 2 questions for you all today. The first one's going to be a preeclampsia question. So the nurse is planning care for a client who is pregnant and has severe preeclampsia. Which of the following interventions should the nurse include in the client's plan of care? So our options are to administer that labetalol, administer carboprost, check our DTRs, administer mag sulfate, or minimize environmental stimuli. It is a select all that apply question, so drop your answers. There will be multiple in the chat. Alrighty, let us know. And you are doing fabulous today. In the meantime, if you have not already, go ahead and check out our Nurse Life videos. We've been dropping about 1 every single week with pertinent information on clinicals, care plans, concept maps. Lately, we've been hitting those topics really hard. We want to make sure we provide you guys with information that's really pertinent to where you are. I know a lot of you are kind of in the beginning to middle parts of that fall semester, kind of probably in the nitty-gritty of your clinical assignments. So care plans and concept maps are a really big part of clinical paperwork. So definitely, in case you have any questions about that, we have a lot of resources on that now. We also do a live concept map once a month. Our next one will be October the 1st, so next Wednesday. We're doing our first mental health concept map. It's going to be on schizophrenia. So in case any of you maybe are in your mental health clinicals, make sure you stop by. That will be next Wednesday at 11 a.m. Central Time. It's some good information. We also have done concept maps, probably 4 or 5 now. We do about 1 a month starting at the beginning of the summer. So we have some past references. We've done a neuro topic, a peds topic, a maternal health topic, a critical care one, I believe. So we've hit a lot of different areas of nursing. So really, I think you should be able to find something that's close to whatever you're looking for. Alrighty, seeing some great answers. So our correct options here were 1, 3, 4, and 5. So why was this? Again, severe preeclampsia is that hypertensive disorder of pregnancy with the element of protein in the urine. So option 1, administer labetalol. This is a beta blocker. It is safe to use during pregnancy. It's used to help decrease that blood pressure. We would want to do this. Option 3, check our DTRs, our deep tendon refluxes. We need to check these often in a preeclamptic patient for 2 reasons. For a client that's on a mag sulfate drip, we have to make sure we're checking these because we can have depressed refluxes if the client is becoming mag toxic. So we check our DTRs to make sure they're not depressed, meaning the client would be mag toxic. And we also want to make sure they're not hyperreflexive because this is an indicator of a potential seizure that's oncoming. So we're checking them for being too depressed and too hyperactive. We want them right there in the middle. Option 4, administer mag sulfate. We just talked about this a little bit. It's a common treatment for severe preeclampsia. It is seizure prophylaxis. In severe cases, clients will be induced or delivered via C-section and remain on this mag sulfate drip for 24 hours post-delivery. And lastly, minimize environmental stimuli. This also helps to prevent that seizure activity. So loud music, loud TV, sometimes even loud family members really need to make sure they're removed from the bedside. We're keeping the lights dimmed low, really minimizing our stimuli here. Our only incorrect option was option number 2, that carboprost. This is hemabate. This is given in a postpartum setting, not an antepartum setting. It helps the uterus to contract after delivery. If there's excessive bleeding, it's usually used in the case of like postpartum hemorrhage. Remember, this client is still pregnant. It's a client who is pregnant and has severe preeclampsia. That's not a drug we give in the antepartum period. So again, 1, 3, 4, and 5 are our correct options. Way to go, you guys. And we'll cap it off with our final question. The nurse here is assessing a client with suspected placental abruption. Which of the following findings would support a diagnosis of placental abruption? Our options being painless bright red vaginal bleeding, rigid board-like abdomen, referred shoulder pain, or uterine atony. Drop those answers in the chat. Let us know what you all are thinking. And definitely check out, we have a lot of exciting things coming up. uworldnursing.com is our home base for everything. You're able to see all of the different topics we're presenting in the coming weeks. I update that calendar every week, so it is current. Make sure you check in uworldnursing.com. You can go there to subscribe. You can go there to check out what topics we're covering so you know when to tune in, when we're covering topics that you guys want to learn more about. There's links to pertinent blog posts to buy our product. So many great resources that it's it's really a great home base for our social media nursing efforts. So check out uworldnursing.com. We also have our final NSNA webinar on October the 6th. That is not this upcoming Monday, but the one after that. We'll be back again next year with 6 more, but this is the end of 2025's virtual webinars. So for anyone that's not able to join in person in the spring or fall NSNA conferences, this is a great way to kind of meet us in the middle and join us virtually. All right, I see lots of great options. And our correct option here, you guys got it, was option number 2, that rigid and board-like abdomen. So placental abruption is the separation of the placenta from the uterus. The symptoms are going to vary depending on the severity of the abruption. It can be partial, it can be complete, sometimes it's really even just like a little edge. So you're often going to see vaginal bleeding with placental abruption, but option 1 is typically not painless. Other symptoms of placental abruption include uterine tenderness, abdominal pain, so there may be bleeding, but it is most likely not going to be painless. This one is incorrect. Option 2, our correct answer, this rigid board-like abdomen. This is a hallmark sign of placental abruption. If you guys see this in any question or answer option, I want a little red flag to go off in your head that's warning you of placental abruption. Lastly, or 3, referred shoulder pain. This can be a sign of a ruptured ectopic pregnancy. It can also be a sign of referred gas pain, but typically not a clinical sign of abruption. And lastly, uterine atony, also an incorrect option. So uterine hypertonicity, or a hypertoned uterus, is more typical with our clinical manifestations of abruption. So essentially the uterus is very contracted, very hard, very toned, trying to clamp off that bleeding, not atoned or atony, which means the lack of muscle tone. So this was also an incorrect option. So again, option 2, that rigid board-like abdomen, is going to be our correct option. Way to go, you guys. So a quick view of our QBank slide for any of our users and viewers who already have purchased UWorld. Here's how to filter our QBank to get you exactly more questions on exactly what we learned about today, so you can test your newfound knowledge. For anyone that does not have UWorld, here's just one of the many, many ways you can tailor and personally filter our questions to get exactly what you are looking for, exactly what you want to work on. Thank you so much for joining us today. We're actually back tomorrow with Nurse Jackie and Nurse Andrew with an antepartum disorder question drill. So you get even more questions based on what we talked about today, which is kind of a fun thing to do. And we'll be back on Thursday with priority questions. So thank you so much for staying tuned. I know that OB and specialties can be kind of different from that mainstream med-surg critical care nursing, but after all, in OB, you're caring for 2 patients at once, the mother and the baby, so you can expect it's going to be a little bit more challenging. But you guys did a great job today. Way to go, and I will see you soon.